Good morning, everyone, and welcome to my YouTube channel, Pain Free Partha. And most of my slides are available for free download in www.painfreepartha.com. Today's topic is going to be a closed loop anesthesia. Now, this is going to be a series of YouTube lectures or videos that is going to concentrate on paper 4 of MD anesthesia, that is recent advances. So what is closed loop anesthesia delivery system? Sometimes they may ask CLAD, closed loop anesthesia or CLAD, closed loop anesthesia delivery. We think that it is recent, AAS come, all these things come. But closed loop control of anesthesia was published in 2002. Now we can see there is something called use of frequency discrimination in automatic EEG control of anesthesia. This is servo anesthesia. See the publication date in 1951. So I will tell a simple example. Thermostat for anesthesia. You can see in pediatrics. It automatically controls and feedbacks. This is simple. Now this is the thermostat. It gives to the monitor, don't go above 36. The radiator, warmer or something stops. This is a simple thermostat of a closed loop. Closed loop systems continuously take data input. What is this data input they are taking? Now it is taking temperature, servo loop, radiator, warmer stops. This is what is called the data input. Now, what is in anesthesia? It takes heart rate, blood pressure, oxygenation, and a processed EEG. Input usually may be processed EEG, hemodynamics. It may be respiratory monitors. For example, a BIS monitor, pulse rate, BP, saturation, EtCO2, end tidal, CO4 in concentration. These are all the input data. Let's get into the control. What is a controller? It is an algorithm or is a processor. It measures the current value. What we have set is the target. And it targets with actual and it does the work. Now, for example, if the BIS is 30 and we have set it as 40 to 60, it decreases the agent concentration. That is how it does. So this is the controller. There is one effector organ. Now, what is it we have seen? The data input system in the controller or the processor. There is something called PID, proportional integral derivative, or AI models. Proportional means there is an immediate response to the current error. BP falls. That's the immediate response. So integral is this is because the BP is falling because the BIS is persistently around 35 or something for the past 20 minutes. Now it has to change the BP, it has to change the IV fluids, it has to change the vaporizer. All these things it does by proportional integral derivatives. Now we get processed EEGs, hemodynamics, respiratory parameters, and it does. Now what does it do? It decreases the anesthetic concentration, it decreases the propofol, it decreases the narcotics or fentanyl. This is what is called the feedback loop or controlled loop anesthesia or the CLAD. Now is the effector delivery? Maybe a TCA pump, it may be an automated vaporizer, it may be a syringe pump. All these things are possible. We can give propofol increase, fentanyl decrease, volatile sevoflurane increase or decrease. All these things are the effector system. The drugs used may be propofol, dexmed, opioids, agents. Very rarely they have reported with local anesthetic agents. Now, what is the level of automation? Decision support only. Now the business decreased to 30. Now you do something. It gives the order. Now we have to do it. The second thing is semi-automated. It tells that the business is falling. We have to decrease the vaporizer. And if you tell yes, it will do. Otherwise, it will not do. This is semi-automated. Fully closed loop means this is 30, it will decrease the vaporizer setting. This is the level of automation what we have in closed loop anesthesia. Yes, the clinical applications are high risk surgicals, elderly, obese, pediatrics, so many patients we can have. Now, what is the use? Why do you want closed loop? Improved precision. Yes, we are in 1.2 Mach. Reduce the drug consumption. For example, if we give propofol extra, we may give 25 milligrams. but it will give only 15.5 or 16 milligrams only. So drug consumption is decreased. Response is faster. Now you see the clinician has to approve and yes to give means it will take around 3 to 4 minutes. But here it is not like that. So it doesn't fluctuate. Heart rate decreases, immediately it will give. Heart rate increases, it will give analgesia. So the response is so quick and reduced humor errors. And it performs again, the same thing. For example, if you are going to give fentanyl 10 mics, as the effector, it will give again 10 mics consistently. We may give 12.5, we may give 15 or something like that. Lower workload, yes, we can set up the system and go have some other case, next day case pre-op checkup. Potential faster recovery, but we should be focused. There is no non-supervised closed loop. Think of that. Just we cannot go for coffee and relax. A study in the multi-center setting proves a closed-loop anesthesia system is compared consistently better performance. This is in 2016 anesthesia analgesia. Here, the accuracy of closed loop versus open loop propofol. What is this open loop propofol delivery system? Now, the propofol is being injected. It shows the BP is 80, 60 and pulse rate is 75. Now, we go and decreases. That is open loop. So, lower out of that, the cost of greater consumption of propofol. Yes, lower vis variability, out of range values are not there. It becomes between 40 to 50 only, but sometimes the consumption may be little higher. Okay, now these are the advantages. Precision, less drugs, all these things are advantages. It consistently does this. Anesthetist can relax. All these things are advantages. But what are the problems? You need sensors. BIS has to be pakka. Okay, if the BIS monitoring is not good, if the so-called sensors of EtCO2 or the vaporizer agent concentration, then it becomes dangerous. There are limitations for the algorithms. There may be a risk of inappropriate need for human oversight. Technical failure risk, it may not push properly. High cost. Training requirement, the staff need expertise, how to use it because it's a new equipment. It is costly. So it is not universally validated. Sometimes the validation in Europe may not work for India. So if the closed loop anesthesia systems works badly, it fails and the patient becomes bad. He has become brain dead. Who is responsible? Because it's an ethical issue. We are the anesthetist. We have started the closed loop system and it is giving. This is decreased, it is decreased agent. So all these things at last, if the patient wakes up, he doesn't wake up. So the system fails. Legally, the anesthetist is responsible. Closed loop system anesthesia, yes, we need to have a lot of Indian studies. Now we have told the data input is about heart rate, blood pressure, EtCO2, end-tidal agent concentration, and BIS monitoring. All these things are calculated and put. But can we integrate urine output? Urine output is very important monitor set. I want to integrate with closed loop system. This is very difficult. Yes, we can use it as an adjunct. That's because if the cardiac output falls to 9, decreased BP blood pressure decreases to 90 or less, the urine output will decrease 2 hours. Where is the question of urine output integrating? It is fast. So, slow response, non-specific. For example, the patient may be having diuretics. It is too delayed. It is not a measure of depth of anesthesia or analgesia. So, the two things, it is a measure of cardiac output. So, all these things makes urine output is a secondary factor, not the primary thing. It is an adjunct or a secondary feedback parameter. Okay, now the BP is falling because of the agent. Agent is decreased. Now the BP falls due to blood loss. The system is confused. Then now the BP blood loss is there. The heart rate is slightly more. BP is less. And the target, we know the heart rate is 100 is high. The BP is low. What does it do? PID, it integrates and likely actuator is propofol decrease, agent decrease, all these things. Heart rate is increased, sometimes analgesic may be increased. All these things we don't want. We want IV fluids. We want blood to be replaced. Yes, that is what is the problem with these closed loop anesthesia systems. Can a systemic illness like diabetes, hypothyroidism, all these things be integrated? For example, diabetics may have autonomic neuropathy. Hypothyroidism are likely to bleed. They are more prone for sedatives. All these things. It is very difficult to integrate all these things. So all this chronics does not change second to second. It doesn't change second to second. Not measured continuously. Like you cannot go on measuring T3 continuously. Baseline physiology. So even if it is going to be sugar, we are monitoring every hour only. We are not monitoring beat to beat. Or can we influence the autonomic nervous system instability to this? Yes, it may be a secondary thing, but presently, no. Now we have a patient with a liver disease. We have a patient with kidney disease. What happens? A healthy patient gives a propofol. Patient responds, the closed systems, values are activated, stable anesthesia dips, BP is wanted. Now you see here, patient with liver or kidney disease. The BIS is 20 because the BIS falls more than expected. Detects values below target. Excessive death and hypotension. But the recovery may be slow. That is the problem. The patient may not come out fast because you have given sevoflurane enough to cause a BIS of 20 because the patient has liver disease. Patient has got a kidney disease. All these things have got a problem with this closed loop anesthesia integration. Now, this is as direct, fast can be done. Yes, the only problem is about electrocautery. Blood pressure, heart rate. Yes, reflex hemodynamic changes. EtCO2 agent. Yes, real time in respiratory managed. Influenced by ventilation perfusion changes. Saturation. Yes, sometimes you can access an adjunct. It's a late indicator. Urine output usually no in the primary loop. Low, delayed, non-specific, slowly changing. Temperature, no. Reflects thermal balance, poor correlation with anesthetic depth. But temperature can cause problems in anesthetic depth, can cause problems in neuromuscular blockade and recovery. This temperature cannot be integrated with closed loops. Regional anesthesia is not developed at all. Can you give spinal care, how to integrate, can you give epidural, and these things are completely not under the closed loop so far. May be employed in neurosurgery to maintain stable anesthetic depths, limited by individualized control of cerebral physiology. How is this cerebral work? How is this neuromonitoring? And frequent clinician. Surgeons shift the brain, push the brain. All these things are there. That is very also important in patients who are having thoracotomies, lateral position, all these things. So this may cause problems. Hemodynamics may change. We have to be careful. Can we do in ectopic pregnancy? The problem here is stable physiology, closed loop is better. Unstable physiology, not a good candidate. This we should remember. Yes, laparoscopic cholecystectomy, position changes. Patient becomes pneumoperitoneum and patient is head up and the BP falls. What does it do? It decreases the agent, it decreases the propofol, it decreases the analgesics. This is what we want. No, we don't want this. We want head up to be, we need to supervise this. Very important because headache may cause BP to fall. And this should not cause sevoflurane to decrease. That is what the closed loop anesthesia is. We are all powerful clinician supervised automation tools. Here we have retained the full authority to override, modify, discontinue. Closed loops assist us, but does not replace. How manual control? You can override, switchly manual, go to manual. You can change the target values, blood pressure, heart rate. For example, if the patient is having a BP of 180, we are taking as an emergency, and we keep a heart routine BP as 90, then it is not good. So we have to adjust the target values. You have to modify the algorithm settings. You have to directly control. Yes, manually set. If that is doing, we have to set. Yes, some pass or disable closed loops for some time. This is how we can overcome, a clinician or the anesthetist can overcome the closed loop. So what is it? Three main parts: input, controller or the processor, and the effectors. Advantages: yes, precision is there, less work for the anesthetist is there, consistency is there, less doses are there. All these things are advantages. But disadvantages are so many. We cannot use in regional anesthesia. We cannot use in ectopics. We cannot use when there is a bleeding. We have to overcome all these things. Scenarios and problems, liver, kidney disease, diabetes mellitus with autonomic neuropathy. Yes, they cannot be included in this. Can urine output be included? Very difficult because it's a late changer. Thank you all. My slides are available in painfreepartha.com and subscribe to Pain Free Partha in YouTube. Listen, enjoy. Thank you.